All right, that's everybody's cue to stop talking. Okay, here we go. People are rolling in. We have an exciting presentation today in a different environment. Hope everyone appreciates the temperature-controlled environment that we're in here. And today, I'm really excited about this presentation, which is called Communication Coaching, Improving the Clinical Learning Environment and Patient Outcomes. One reason I'm excited about this is because it's really important. It affects many people in our medical center and elsewhere. It affects medical practice. I've also been trying to get the group here to give a presentation on this important topic for at least 2 years. I've forgotten how long it is, but finally today's the day. Our presenters are Lauren Decaporale-Ryan and Susan McDaniel, both faculty members in our department. And before we get started, I want to give the usual housekeeping reminders. Okay, so first, if you're watching this on Zoom, your camera and microphone are off. So don't try to turn them on. You won't be successful. Second, please don't, if you're on Zoom, don't use the chat function. We reserve that for the speakers, panelists. Woe to anyone who tries to use the chat function. I've heard there will be an 8-hour MyPath remedial instruction for anyone who does that with no, and the fast forward option will be turned off on that. And very importantly, please fill out the evaluation at the end of the presentation or possibly tomorrow. So there'll be a link that'll come up on a slide at the end and in the chat box and an email tomorrow as well. So there'll be 3 opportunities to do it. All right, so now we're going to hear about communication coaching. As I said, I think this is a really important area, given the data that we'll hear about on physicians and how they talk to patients and other providers. And we don't really see a lot of this work happening in psychiatry because a lot of it happens in other departments. So it's really important, I think, that we all get a chance to see this presentation. So without any further delay, let me introduce Doctors Ryan and McDaniel.
Good afternoon, everyone. It's a pleasure to be here with all of you today. I'm going to just walk us through some additional housekeeping here for the sake of everyone's CEUs. So today we have no disclosures, and we want to think about, through this activity, describing to you the original objectives of the URMC Communication Coaching Program, which you'll hear is a large institutional-wide initiative, as Steve has articulated. And we'll talk about how surgical education fits specifically into that. We hope that you'll also be able to list 2 effects of the clinical learning environment on communication behaviors and describe 2 outcomes of having communication coaching on the learning environment, and consider within that how this fits into the context in which you work. We have no disclosures. And with that, what I'm going to ask is for Dr. McDaniel to kick us off and share some about the program history. Before I do that, I want to just acknowledge those who contributed to the coaching program and to today's presentation. First, we want to note that a systems-wide project for the Executive Leadership in Academic Medicine Fellowship Program was the genesis of the UR Medicine Communication Program with Dr. McDaniel, as well as the Macy Foundation supporting an early project in surgery headed by myself. We thank Ben Lee in the Department of Psychiatry and David Lenahan in the Department of Surgery for their support of our coaching initiatives, along with surgical education team. We also want to acknowledge our senior coaching team, many of whom you'll see around the room today, for their contributions and efforts. Our senior team members, past and present, have been influential to this work, serving as outstanding consultants and innovators in education. The current team includes Drs. Keisha Bell, Rebecca Kopek, Andrea Garraway, Jesse Moore, Natercia Rodriguez, Sephora Rosenberg, and Lindsay Sitch. Holly Weldon is our psychology fellow embedded in surgery, and though she can't be here today, she has played a substantial role in evaluation of the program and to today's presentation. Finally, we want to thank the learners. residents, fellows, faculties, and teams that have embraced this learning, who continue to strive for excellence in all areas of healthcare delivery, and who push us to think creatively about how to enhance learning in 2023. Susan, over to you.
Hi, everybody. It's great to see you. Thank you for coming. So before I talk about the development of the communication coaching program, let me just fix this here. Okay. And its application to the Department of Surgery, I want to start by saying the program now, 12 years later, is multifaceted. Communication coaching starts with a standardized program for faculty, residents, students, teams, and researchers in the full range of all their settings: acute inpatient, ambulatory, the OR, the ED, research labs, etc., using all the tools that seem appropriate to that context. It also often involves leadership development, including increasing self-awareness and self-regulation, professionalism, mindfulness, systems thinking, context and situational awareness, mindfulness, and anti-bias training. We do this in collaboration with partners such as those in OEI, faculty development, BHP and EAP, and WellU, as well as sometimes external coaches. And the other part of what we do is focus on training new communication coaches, as well as evaluating and disseminating the program. Okay, so that gives you the context of where we are now. I want to talk to you a little bit about where we came from 12 years ago. So the goal has always been to create a culture of feedback and wellness throughout the medical center. Our approach draws on that of two of our department's pioneers. You can name them with me: George Engel and Lyman Nguyen, both of whom I was fortunate to work with at the beginning of my career. Engel's biopsychosocial approach and Nguyen's family systems therapy both derive from general systems theory that swept the sciences in the early 20th century, and then the social sciences in the second half. Our work combines theirs so that we focus on a systemic biopsychosocial approach in clinical, educational, and research contexts. So I'd like to share with you how we've applied the approach to various healthcare arenas using the tree as a metaphor. With general systems theory at the root and biopsychosocial medicine and family therapy at the trunk of the tree, we've applied this to patient care with family-oriented primary care, integrated primary care, medical family therapy, and integrated specialty care, all of which we call systemic integrated care. As this work continued, we began to study clinicians and teams and the communication necessary to provide good patient and family-centered care. These studies led to more intensive research on doctor-patient communication, from which I developed the physician communication coaching program. All this work demonstrates the power of relationships to promote healing for patients, families, and other health professionals. Fundamental to all this is communication and its complexity with families, teams, and doctor-patient relationships. As George Bernard Shaw said, the single biggest problem in communication is the illusion that it's taken place. Then there's a great quote by the Department of Defense and Pentagon spokesman, Robert McCloskey, who said, "I know that you believe you understand what you think I said, but I'm not sure you realize that what you heard is not what I meant." And we see a lot of that studying communication. With this in mind, I'm going to turn to the coaching program, where we work directly, as I said, to create a culture of feedback and wellness, using systemic principles in order to enhance the elements of communication and self-awareness that are part of lifelong learning for all of us. Keisha Bell, one of our coaches who's embedded in OBGYN, described the goal of communication coaching as seeing patients accurately and intentionally, and seeing ourselves accurately and intentionally. The development of this program began in 2011 and 2012 when I needed a systems-wide project for the ELAM Fellowship that I was part of representing URMC. Dean Taubman asked me then to develop something to help with patient satisfaction in response to patient complaints, as well as the fact that patient satisfaction was about to be monetized and would drive some of hospital and physician reimbursement. After reviewing the literature, I chose the evidence-based Calgary-Cambridge Patient-Centered Observation Communication Checklist of 30 communication behaviors that correlate with both patient satisfaction and positive health outcomes, because as you think about it, I'm sure you know, they aren't always correlated. We wanted both, and added to it 7 items based on my own research about communicating with family members and recognizing the importance of patient and family affect. So I developed a process that includes observation of physicians seeing patients for at least 4 hours to get a valid sample, then compiling both the quantitative and qualitative data, writing and sending an extensive detailed report that paints a picture of the physician as communicator, and then meeting with the physician to debrief the experience and discuss both their many strengths and some concrete behavioral recommendations for improvement. The result is a program that we feel is personalized, evidence-based, and helpful to the most as well as least experienced physicians, those with the highest patient satisfaction scores and those with the lowest. We want a program that promotes a culture of support and feedback throughout a physician's clinical career. About the same time as I was developing this coaching program, Surgeon Atul Gawande wrote an article on coaching on surgery for the New Yorker magazine, for which I was grateful. He said, no matter how well-trained people are, few can sustain their best performance on their own. That's where coaching comes in. And he talked about athletes who continue to have coaches, musicians, other high performance people who continue to have coaching throughout their career. And yet in medicine, largely speaking, you get trained and then best of luck. And his article also describes the anxiety most of us feel at being observed, then the reward that comes with being accurately seen and receiving useful feedback. After developing the program, I ran a pilot to understand what our physicians at U of R need and to check for feasibility of the program as it was designed. And I included 2 groups of physicians from a variety of medical specialties. Participants were 6 surgeons and 6 cognitive physicians, 6 with high patient satisfaction scores and 6 with low, and it just fell out to be 8 men and 4 women. In the analysis, I focused on 3 of the 45 skills that were highly correlated with patient satisfaction and positive health outcomes, and found that our participants' performance on these skills predicted whether they were in the high or the low patient satisfaction group to a 0.0001 level, which I have to admit surprised me, but there it was. So it made me feel like, okay, we're on to something. And I'll share with you a few of the other perhaps random results just to give you a sense that you might find interesting. Physicians with high patient satisfaction scores were 10.5 times more likely to ask about patient concerns. And female physicians were 6 times more likely than men to actively check for understanding at the end of the visit. This communication skill also discriminated between physicians with high and low patient satisfaction scores. Check for understanding is one of the top 10 safety practices recommended on the strength of the scientific evidence by the Agency for Healthcare Research and Quality, because less than half of patients, when they walk out of their visit with their doctor, can tell a medical student or a research assistant exactly what their diagnosis and treatment plan is. Remember, this is independent of IQ and education. People still can't do it. So that's why check for understanding is so important. After the pilot, as is true now, We sent an anonymous survey monkey out to the participating physicians in the study. I will say that even now, physicians are rarely excited to participate in this program. There's exceptions, but a lot of people are referred because their supervisor thinks it's a good idea, or because they have to, or they do it for malpractice reduction. But after receiving the report and attending the hour-long individual debriefing session, it's almost universally regarded as a very positive experience. Here's the feedback from the pilot. 60% of participants rated it as very helpful and 40% rated it as helpful. And a year or two later, if you look to the right, it got better with 83% rating it as very helpful. Besides the rating, we also always ask for comments, and here are a few from the pilot. She showed me all the things I was doing correctly and pinpointed some areas that could be tweaked in the future. I think every provider in our department should meet with her. I believe this type of experience is valuable since habits, good or bad, creep into communication. Very professional and insightful. I'd like to do this again. She made me realize that I did a lot of teaching, but did not always elicit patient concerns. And my personal favorite comment, very helpful indeed, even though it was truthful. So as Bill Watson said when he was serving as a coach in 2013, the idea is that we all have blind spots, don't know everything, are constantly missing things, can improve our practice in critical ways, and most importantly, can learn from others who aren't of the same discipline. One could say that coaching is subversive in a good way to the dominant culture of the disciplinary silo. We're working to create a culture that welcomes rather than avoids feedback, and we're convinced that a collaborative biopsychosocial approach to health, illness, and disability is humanizing. Lauren?
So I'm going to start by walking you through my journey in surgery before telling you a little bit about the outcomes of the program. When I initially joined the Department of Surgery, I spent my first several months shadowing, joining residents anywhere from their intern year to a PGY7, as well as faculty and APPs. The department has multiple divisions, and during my first several months, I spent the majority of my time rotating between the trauma service, colorectal surgery, burn, pancreatic, and pediatric surgery teams. To join these teams required arriving for 4:30 a.m. rounds with junior residents. I relatively quickly discovered that no one is particularly interested in best practices in communication at that time of day, myself included. Most of us were barely awake. This was exacerbated by the fact that most coffee shops on campus don't open till 6 a.m. Now, you might be wondering why coffee is important to the context of the presentation, but I invite you to begin to consider how this might feel to learners and those around them. They are working an 80-hour work week, they are fatigued, and when I first began, they often didn't have access to the things that would support their basic well-being. Residents were initially cordial, though trepidatious. Early on, one said to me, "You are terrifying." The descriptor didn't really align with my self-assessment. When I asked what made them say that about me, what quickly became apparent was that the concerns regarding coaching had nothing to do with me, but with the process. This resident and others began to label that having their communication skills observed meant that they were being evaluated on yet another skill. And while many were taking the time to teach them technical skills, they had had minimal learning on how to communicate with patients or with each other. Ensuring that they could see this process as a formative rather than a evaluative one became a critical part of the education's team mission. It also meant that residents needed to see their faculty participating in coaching to normalize the process and to champion it. Many wondered and remarked early on that they thought people might change their behavior in response to having a coach present, routinely naming the possibility of the Hawthorne effect. Of course, people did change their behavior in response to me. Some of this was subtle, and some of this was explicit, like showing up to a division morbidity and mortality conference and having someone say, "Shh, the psychologist is here. Best behavior, everyone." This was okay, because if they knew that they could communicate differently and perhaps should be communicating differently, and they demonstrated the capacity to do so when I was there, then it meant that perhaps we could change behavior in a more sustainable fashion if some time and attention were paid to it. As I began to implement our coaching protocol with the residents, the move from observing to learn to observing to coach was not without bumps in the road. I had residents tell me they didn't need coaching. And because we were aiming to be formative, we didn't really have a plan yet of what to do with learner resistance. As Dr. McDaniel mentioned, just prior to my entry in the department, Atul Gawande had written that piece in the New Yorker. He wrote, knowledge of disease and the science of treatment are always evolving. We have to keep developing our capabilities and avoid falling behind. So the training inculcates an ethic of perfectionism. Expertise is thought to be not a static condition, but one that doctors must build and sustain for themselves. He highlighted that coaching had the potential to support not only technical skills, but that it could support other aspects of professionalism and creativity. He again argued everyone needs a coach. And so there was some traction. Many would tell me, though, that it was fine for me to have observed their work. They didn't need to debrief. Despite this, every resident I'd observed eventually showed up at my office door. Though I'd say I only had 30 minutes available, the first 7 residents I sat down with all remained in my office for a period of at least 90 minutes. Almost all of them said something like, no one has ever given me feedback. And what I began to learn was that there was a culture within surgery. When faculty weren't saying anything, that was feedback. It meant that a resident was entrusted to continue and had demonstrated competency. But with a new generation of learner came different needs. Silence could not be the method of feedback, and role modeling of behavior might not be enough. During the early days of my observing a resident, I wrote the following notes to myself. Clinical learning environment substantially influences resident role, how they function, what they see as their responsibility, what faculty expect of them. Environment also influences stressors, patient volume, acuity, potential need for debrief. There's a link between professionalism and well-being that we need to address. These reflections were then captured unintentionally by a resident. There'd been an adverse patient event, and following the patient-resident interaction, a faculty member asked, "Could you have done anything differently?" The resident replied, "I honestly don't think so. We have numerous consults today, and we had to see 22 patients. You want me down here by 7 for a report, so taking more time is impossible." The faculty replied, "You're right. We like to start on time, but it's important that our patients feel safe. Slowing down to provide some guidance could have helped you both. And if you tell me you're late because you did something like that, end of discussion." With departmental leadership support, we began to address the environment, but first we needed to more fully understand it. 24 residents were observed on 3 services, representing a total of 373 patient interactions, including 122 at Highlands General Surgery rotation, 96 in pediatric surgery, and 155 on the trauma acute care service. Residents were observed in a minimum of 9 interactions with a maximum of 25 interactions occurring on trauma, and the average number was 15, with residents most traditionally interfacing with more families on pediatrics. Looking at frequency of behavior, you can already begin to see a story emerging. Communication patterns were different across settings. The most utilization of behaviors we know to be influential to patient satisfaction and outcomes were observed on the pediatrics rotation, slightly fewer on the community rotation, and substantially fewer on the trauma service. Notably, residents introduced the team more often as on trauma as compared to when at Highland. You can imagine that their patients are interfacing with far more people in that setting, making it all the more important. And while the pragmatics of sharing next steps was something that residents did relatively consistently across all settings, the capacity to respond to patient cueing for empathy varied tremendously. Looking at these behaviors more closely, you'll see that there are statistically significant findings which represent changes in behavior frequency demonstrated by this sample of 24 residents. We went on to analyze the probability that each behavior was observed, utilizing odds ratios to represent comparisons between behaviors observed on rotations. Values under 1 indicate more skilled communication in pediatrics in the first comparison of community versus peds, while values over 1 indicate more skillful communication in pediatrics compared to trauma. As you can see, the odds ratios of the vast majority of behaviors occurring in the community versus pediatric comparison are less than 1. indicating that the presence of the target behavior is less often observed in that community setting as compared to the pediatric setting. Here again, you can see that the only behavior that did not have significant differences was how residents introduced the team to the patient. Only one behavior, showing courtesy and respect, was not significantly different between pediatrics and the community setting, indicating that such behaviors occurred with similar regularity in both contexts. However, you can also see that rates of courtesy were much higher on both the community and pediatric setting as compared to the trauma service. This was captured in simple but important behaviors: closing a door or drawing a curtain for privacy, muting the television, but then leaving the remote such that the patient couldn't access it as the team was leaving the room, drawing a blanket down and never pulling it back up for someone who could not reach it. All of these simple steps take time. As I noted before, the frequency of responding to empathic cues was generally low as compared to other behaviors. While residents were relatively comfortable using reflective listening skills like acknowledgements and affirmations, they did so variably across the settings. These behaviors are the building blocks for empathy. Past studies, including several conducted here, reflect the tendency for clinicians to quickly turn to a biomedical inquiry when patients present with affect. But we also know that physicians can respond with empathy. Interactions are often de-escalated, patients feel better heard and understood, and are able to differently participate in their own treatment planning. These patterns of varied communication behaviors between services were observed from start to close of the encounter. In one of my most memorable moments in the early days of coaching, I watched a resident back out of the room, in essence doing the moonwalk, while the patient was still talking, asking medically relevant questions regarding his preparedness to go home. The resident didn't have time to share next steps, aside from, "We'll be sending you home later today." He didn't ask if the team could do anything else, nor did he say goodbye. Just outside the door, the resident shouted, "Okay, we'll try to be back this afternoon. Call if you need us before then." You can hear the irony, the suggestion to call if one needs anything as one is actively telling you what they need. It was both problematic and also quite common at the time. You've heard the perspective of one resident regarding a lack of adequate time and the role that played in the inability to slow down and connect. But how might these differences otherwise be explained? Feedback with residents became revealing about the factors they saw contributing to changes in their own patterns and approaches. For one, they said, "When I walk into peds, I see the faces of my own children. It's easier to ignore them, the kids. Focus on the parents, get to the OR, call it a day." This was a defense mechanism that made it easier for them to most effectively do their job and remain focused in the OR. Another, "I know patients have to trust us, but I don't want to connect before surgery. I need to be able to cut them open. I'm not going to sit down and have conversation first about who they are. I'll get to that later." For another, "On some services, I feel I have more autonomy. In those spaces, I know that the patient is relying on me more. I'm there to be a liaison to my faculty, so I need to take more time to listen. Sometimes I just can't though. Like with that guy, I don't have 15 extra minutes to talk about sending him home when I've already spent 3 minutes on the topic." And for another, "I trust my faculty to teach me in the OR. I know that I will graduate and be able to operate safely, but I'm not sure that they always know what to say either. We don't have consistent role models." This same resident went on to reflect their awareness that faculty are not all trained medical educators, and that the culture of surgery and academic medicine had changed drastically with time. Behaviors that were once tolerated no longer are, and surgeons from increasingly diverse backgrounds were and still are entering the workforce with different learning needs, communication styles, and expectations regarding what creates a psychologically safe environment and effective teaching space. We also wanted to understand team dynamics better. Specifically, what did residents and faculty think were core communication behaviors that demonstrated the capacity to work amongst and lead an interprofessional team? We surveyed residents and faculty about these behaviors that they thought important and what they thought best practices for learning these behaviors would be. I want to highlight just a few of the findings for you. We had a total of 68 respondents representing 37 faculty and 31 residents, ranging from senior instructor to full professor and residents from intern to PGY5. First, we asked, based upon your experiences and observations, what do you feel are the 3 most essential characteristics of an effective leader? Residents and faculty alike highlighted that to be an effective leader, surgeons need to have solid skills as a clear communicator. This was followed by being motivational, and fair and decisiveness had an equal number of respondents. Overall, faculty and residents had approximately similar perceptions of what makes an effective leader. One interesting finding is that only residents identified the importance of a leader's capacity to appreciate the team. They were also asked to consider how much they believe these skills are innate versus acquired. Residents and faculty again rated this similarly, with both groups identifying that they are about equally innate and learned. Faculty felt only slightly more that these skills are innate, but this finding was not statistically significant, as residents also leaned slightly toward innate. Residents and faculty were asked what they thought would be helpful content in a learning curriculum focused on non-procedural skills. You can imagine that, again, I heard a lot about time and the inability to implement something like this. Despite that, they all recognized that assertive, effective communication was important. This was followed by the need for interprofessional communication, specifically how to bring a team together, and emotional intelligence was collectively third. In qualitative remarks, residents described that they wanted to know how to tell other disciplines how to approach their work. They found that being assertive was often not enough, and that they felt devalued when in a consulting role or speaking to staff who had been embedded on units longer than the residents had rotated through a service. What they described did not sound assertive or effective, but rather bordering on aggressive, leading us to wonder more about what their approach might actually look like, and if part of why they were struggling was because their intentions didn't match how they were being perceived by team members. Despite the experience of limited time, whether at the bedside in interactions with each other or for the possibility of additional education content to be added to the curriculum, surgical researchers and educators were beginning to demonstrate the importance of patient satisfaction and articulating that it could be achieved in spite of time limitations. There was also a call to action from numerous societies, including the American Board of Surgeons, the Association of Program Directors in Surgery, and the ACGME, that surgical residencies place more attention to communication, teaming, and systems-based practice. Take, for example, the work of Sy and colleagues in a 2015 Annals of Surgery article, in which the authors shared, among U.S. hospitals that perform major surgical procedures, hospitals with high patient satisfaction provided more efficient care and were associated with higher surgical quality. Our findings suggest there need not be a trade-off between good quality of care for patients and ensuring a positive experience for patients. These early findings internally regarding behavior, along with the literature reflecting patient satisfaction, could be achieved despite systems levels issues, led us to wonder, can we create a culture across divisions that reflects our mission and values more uniformly? Could we help residents implement what they already knew to do, but were using variably? And if so, how? We asked two subsequent questions to guide our work. First, how could we support faculty to development to enhance their skills as communicators and to ensure more role modeling was happening? And second, what could and should be done to promote learner wellness? Because when you're arriving at 4 a.m. and worried about making it to 7 a.m. meetings such that you don't slow down to greet a patient, there are underlying risks of burnout, fatigue, and depersonalization, to name a few. To support faculty development, we implemented a training program for surgeons at all stages of their career and across divisions. 12 faculty participated in a pilot, which included a didactic session that introduced them to key communication behaviors, how to identify those behaviors in real time and code for them, and how to give feedback. This session was interactive in nature, with surgeons watching a range of clinical scenarios from bad to ideal and coding them, talking about how they would give feedback and role playing. Thereafter, surgeons participated in 2 cycles of observation. Surgeons were paired A and B, and these pairings were intentionally across different clinical divisions so that physicians could focus on communication behaviors rather than on clinical decision-making. These pairings then worked with members of our senior coaching team. In cycle 1, Surgeon A would observe B on rounds, coding their communication and providing feedback. The expert senior coach would also be coding and deliver feedback to Surgeon B regarding the communication behaviors observed, as well as provide feedback to Surgeon A regarding how they approached the feedback delivery process. Surgeons would then switch places, with Surgeon A going to see their patients and Surgeon B completing the coding and feedback process. Approximately 2 weeks later, the process was repeated, though we reversed who was seeing patients first. We wanted to assess how well surgeons were able to observe and code behaviors in comparison to our expert coaches, and wanted to be sure to consider how raters coded with respect to cycle, first or second, and time, rounds A or B within that cycle. Each of the behaviors were dichotomous variables. Did the behavior happen? Yes or no? This created repeated measurements for the pairs of raters, and the potential correlations of those repeated evaluations were assessed with the generalized estimating equations approach. The model of observation sessions looked at the rater's level of coaching experience, that expert coach versus our learner surgeon, and the cycle 1 versus 2, and round A or B, and the interaction of position and cycle. Looking at the evaluated behavior types, which included items tied to initiating the dialogue, nonverbals, gathering information, building a relationship, explaining a plan, and closing the visit, we anticipated that expert coaches would be more discerning, endorsing behaviors as occurring with less frequency than the peer coaches did within that first cycle. We did anticipate that by the second cycle, identifying behaviors would be more consistent between the two groups. Generally speaking, only initiating the visit actually followed this pattern in a statistically significant manner, behaving as hypothesized, where the odds of the expert coach scoring a 1 in that first cycle was less than 1/5 of the time compared to the learner surgeon. In cycle 2, the expert was only half as likely to code as compared to the surgeon. Observations in the other category of nonverbals and body language were in the direction hypothesized, but not significantly. And the other behaviors didn't anticipate as we hypothesized at all. Only explaining the plan followed the predicted behavior at cycle 2, with the expert identifying the behaviors present twice at the rate of the learner. This result certainly requires further explanation. Though you'll recall that we intentionally paired people across divisions, some feedback suggested that surgeons were still not able to drop the clinical component of things and were distracted by the medical content, wondering if one perhaps hypothesis is, did that influence the coding? One surgeon said, "I didn't give you credit for explaining the diagnosis, but I guess you did. It's not what I would have said about it. I would have said," and went on to explain. As you can hear from the surgeon's remarks, the process of feedback involved the peer surgeons routinely being explicit in how they would do something. Residents noted that aside from silence, they also struggled with this because faculty would sometimes either lack specificity or their feedback would be driven by their preference. Dr. X would do it this way, Dr. Y would do it that way, but recommendations were by style and not by learner need, nor necessarily by evidence base. As part of this intervention, we wanted faculty to explore their own feedback delivery. Was their approach like frog, captured here, or did they think they were providing a more in-depth approach? On a scale from rarely to often, we asked them to consider if they picked an appropriate time and place to give feedback, if they provided detailed information about a person's behavior or performance, if they provided context regarding how the learner's actions were impacting the individual's team or patient outcome, and so on. Most reported that regarding their individual behaviors, that they found that they were using some of them only some of the time. There were qualitative remarks that reflected that they had a hard time navigating a learner's deficiencies or gaps, and that they only focused in on strengths because it was easier to talk about. They were also able to name their own avoidance and to recall their own experiences and how they had influenced their approach to giving feedback. 3 cited gratitude that we were facilitating faculty development on this topic, noting no one had ever taught them in their career how to provide constructive education, and that they felt it was important to begin introducing this topic early on to shift the educational landscape. In looking at the surgeons versus expert coaches' behavioral approach to feedback delivery, there were several key differences. Here we asked the expert coach to observe and rate the approach to feedback. Did they identify goals for the conversation? Did they ask about their peers' experience of being observed? Did they provide recognition of their peers' strengths? Did they explore what could have been done differently? And did they set a goal for their peer to work on that was a shared goal and that included some form of follow-up? The surgeons then also used the scale to provide a self-assessment and peer feedback. Given the self-reports that we had initially received, with surgeons rating themselves as only sometimes using best practices, we anticipated that expert and self-evaluations of how feedback was delivered would be most aligned, while the learner being assessed might be kinder to their peer, i.e. that the surgeon's behavior when delivering feedback would be described more positively by their colleague. With 17 separate feedback behaviors, we combined information from all items to look at outcomes in relation to position, cycle, round within cycle, cycle by round interaction, and position by cycle interaction. This table captures the main effects as well as the interaction terms of interest. Values under 1 reflect the learner receiving feedback endorsed their peer as having more skill than the expert did, and that experts also rated fewer behaviors as compared to the self-appraisal of surgeons delivering feedback to a peer. Values over 1 reflect that the learner receiving feedback endorsed their peer as having more skill than the peer did on his or her self-assessment. Looking at the odds ratios for comparisons over the cycles and rounds support our hypotheses about coding of experts versus learner and self in relation to time. Recency may have played an important role when we see that there is evidence of round A or B within the cycle showing significant differences, suggesting that peer delivery in round B was benefiting from observing round A. Anecdotally, junior clinicians were more likely to dive into feedback and share candid opinions with their senior colleagues, whereas those with more experience were more apprehensive to share critical feedback. To most effectively develop faculty skills in feedback reflected that we might need to think about a different methodology as they were not sustaining change, most especially for those who had been giving feedback for a longer period of time. What this initiative emphasized for us is that going through surgical training, or perhaps more broadly, medical education of any kind, doesn't inherently make you an expert in how to teach future learners in that field. Audio recordings of the feedback sessions and debrief revealed important themes that we need to consider. One surgeon said, "I see the difference. When I gave feedback, I told my colleague what I would do. When you gave feedback, you invited them to consider a different possibility. It wasn't about cutting a behavior out, it was building off of what my colleague was comfortable with." And another, "I imagined walking in today and not getting wrapped up in what I would do and just listening and watching. But it's hard to turn off your opinion. Can you train that out of yourself?" There's not time for this. Healthcare has changed so much. I document 24/7. When I'm not in the OR, I need to catch up on an email. I want to do a better job teaching. It's why I wanted a job here in the first place. But finding time to talk through what I see, why it matters, rather than just saying, "Hey, do it my way," it seems almost impossible. It's neat, at least not something I can do often. And another, "I really want to support residents, but I feel frustrated when they don't take the time to listen. I'm exhausted. Sitting here with my colleague, that's refreshing. Getting to catch up and learn from each other, we don't get to do that, but this is great. I want to slow down, grab a coffee, and have a conversation. I think residents want that too, but when?" Faculty had begun to raise some of the same issues that residents had. Issues regarding time and personal well-being were both being expressed. These conversations bring us back to the second question I posed earlier regarding the role of wellness in relation to communication and professionalism. To address this, we began to look at metrics regarding well-being. In 2014, we surveyed residents and faculty, and results indicated that over 20% of residents and nearly 27% of faculty were experiencing depressive symptoms. 32% of residents and 45% of faculty reported moderate burnout, with another 11% reporting more severe burnout. These findings are consistent with some of the national surveys on this topic. In a 2021 Medscape survey of over 12,000 physicians, 35% of general surgeons reported symptoms of burnout. And other studies have shown up to 70% of trainees suffer from burnout as well as depression. In response, the department quickly took action, offering some simple but important things: access to water and coffee stations closer to their call rooms, delivery of healthy snacks, negotiated reduced rates for meal delivery services, funds to get people to and from home when they were too tired to drive. With the help of our colleague, Dr. Ann Cornell, and former colleague, Beth Dennehy, we began to have EAP and BHP routinely represented at a range of events, from resident onboarding to social gatherings. Our aim was to normalize discussions about wellness, while also naming that no one should be suffering. These initiatives were relatively easy to implement, but with significant impact. By 2015, we had introduced 2 new roles to the department: a faculty ombudsman and a resident peer-appointed ombudsman, who both served as liaisons between residents and faculty, and who could offer space that allowed for honest reflection about what it meant to be a resident in the current educational climate. We also recognized at that time that taking a day to review resident rotations for both the residents and faculty feedback was important, but that was not the same thing as a day of restoration or well-being. We created separate spaces for these things, including more routine town halls so that residents and faculty could have formal space for rotation reviews, and then devoted an entire day to focus on health. This includes sessions on financial health and well-being, physical health, peer support, and other topics that are identified by learners. We spend the afternoon focused on team development with facilitators thinking about the intersection of creating social camaraderie and how that influences outcomes, not only for the patients, but for the teams themselves. In 2016, we began a 2-day offsite retreat that is for rising 3s, 5s, and a small group of faculty focused on the intersection of leadership, professionalism, and well-being, thinking about their various roles and responsibilities at different stages of career. And in 2017, we implemented what is by far one of my favorite events, the Friends and Family Orientation, recognizing that every learner that comes to our institution comes with community, those people who in their life may or may not be relocating with them, but who have known them for years and who know them best, and wanting them to help their loved ones succeed. We introduce them to our personal communities within the residency, what the residency has to offer, and what the university resources are so that they can help recognize when their loved one is thriving or perhaps struggling and know how to help and connect them to resources. And also in 2017, we focused on physical space, ensuring people had an adequate number of beds to sleep in, meeting a basic need, workstations, and for returning to work mothers, pumping stations that were closer to the OR rather than across the hospital. In 2019, we enrolled in the second trial, a national randomized trial aimed to improve the learning environment specifically to surgical education specialties. And in fall of 2019, programs were randomized and as part of participation receive an annual program-specific report that details residents' burnout, thoughts of attrition, suicidal ideation, and this is all benchmarked against programs of similar size across the country. Through these reports, we've learned of specific areas of concern that our residents struggle and face. One of the primary things is how they partner interdisciplinarily with other professional groups. In 2020, we began delivering pandemic care packages when residents weren't able to come to work. And of course, we pivoted to respond to resident needs, running debriefing groups to discuss their experiences related to resources, their fears and frustrations, and to maintain open lines of communication and teach them how to talk through crisis around topics of redeployment, vaccination status, etc. While I'm highlighting resident-focused initiatives, similar things have happened at the faculty level and also in terms of teams in surgical areas of the hospital. Over time, as some of the behaviors have become more a standard part of our culture, like greeting patients, we have been able to begin to shift our focus. In surgery, while Dr. Weldon and I still provide feedback regarding resident interactions with patients and families, we also observe residents and faculty in the OR, providing feedback regarding their communication styles in that space. Are they effectively conveying what they need in that moment? Do they know how to express when they don't know something? And how do you do that in a safe way? We are working with teams, helping units recognize how to capitalize on everyone's strengths and scope of practice and support each other, particularly at a time when teams feel challenged by staff shortages and higher rates of burnout from the pandemic. We are working with general surgery and other surgical subspecialties to expand their holistic interview process. And as part of this, directly support a group interview process that invites applicants to think about how they would fit into our team culture, responding to ethical scenarios and exploring the intersection of their personal well-being and professionalism. These are conducted collaboratively with surgery attendings and residents who can speak to the degree of integration that we have as coaches in their learning culture. And we continue to support the learning curriculum, exploring new ideas and opportunities that support resident growth. For example, we're really excited to begin a new partnership with Dr. Wendy Cross and the Health Lab focused on the role of virtual reality in support of resident well-being when they are on service, promoting improved and immediate access to resources that promote healthy coping strategies and stress reduction. As you've likely discerned, my role as an embedded coach has evolved over time to include a range of activities. This is true of many of our embedded coaches, though for each of us, the core of what we do is intended to improve the biopsychosocial experience of the patient-resident interaction. Here, every pink box represents a department where we have at least one embedded coach. Those in orange are in areas that routinely ask for our help or have requested an embedded coach in the future. In these spaces, our coaches are not only following the standard model of observation, and feedback that Dr. McDaniel highlighted earlier, but they are also supporting efforts that promote physicians as leaders, that train other future coaches to do this work, that allow for bidirectional feedback between faculty and learners, that include difficult conversations and that build a sense of team. Most importantly, each of our coaches tailors the work that they do to the culture that they are in, meeting the needs of the local system and learner environment to promote the success of trainees, faculty, and staff simultaneously. In surgery and other settings, some of the feedback we receive about the importance of our work happens in real time, and some occurs after the fact. Recently, a team member said to me, "I haven't been able to put into words the problem or the solution. Thank you for highlighting both." Our embedded coaches have a depth of understanding about the culture that they are in, while also maintaining objectivity and the ability to observe the situation. It is a balance between being part of the system and seeing the system. Some of my most meaningful moments have been those when alumni have reached out afterward. Some have expressed gratitude, but others have expressed that they're struggling and are looking for help even from states away. One wrote, "It didn't get easier." The fact that people feel comfortable reaching out afterward tells us that our coaching team is helping shift the culture on these topics. We are making it okay to have difficult conversations. We are decreasing stigma and asking for help. We are supporting cultures in naming problematic behaviors and situations and also helping individuals and the systems around them change. It requires our team to have expertise in behavior change and attunement to the medical education landscape, which is evolving. This work is a privilege, and it's been a tremendous gift to collaborate with so many learners and departments, especially for me in general surgery. Thank you for letting us share some of our work with you today and related to the hospital-wide initiative. And I'm going to open it up for questions.
Well, I'll ask the first question. One of the boxes there was psychiatry. Could you say something about?
So we have Dr. Rebecca Kopek, who is in the Department of Psychiatry as an embedded coach, and that has followed part of our standard format of working with residents in a variety of settings and seeing them in practice, as well as some of our senior coaching team working with faculty members across different spaces. And that has been primarily focused on the patient-physician interaction, and in some instances, thinking about the team. And as we think about how that role evolves, that's a relatively new space that we've been in. So it's just beginning to grow in ways that I think will enrich education and other modalities. The other piece that is embedded within the Department of Psychiatry is our coaching academy, which trains our postdoctoral fellows and other clinicians from across the hospital to become coaches. And that is a multi-year training program that emphasizes that medical education competence around culture and understanding the environment, as well as behavior change.
Do you think that if this was done on inpatient units, it might help reduce seclusion and restraint?
Oh, Steve, that's a big question, but I do appreciate it. And so some of the work does happen on inpatient units. Some of the work that I do in surgery happens on inpatient units as opposed to the outpatient clinics. And so certainly it is adaptable and modifiable. And we also have coding tools that we utilize across these different spaces. So there are standards that we have in inpatient settings, OR settings, and the like. Within that, I would say yes, because part of it is getting to know the biopsychosocial needs of the patient and understanding the contextual factors, whether that's the current environment that they find themselves in or the other things that are happening to them psychosocially that are influential to their behaviors. And so therefore we can support them in different ways.
Okay. Well, we have a couple of questions that have come in over Zoom. If you could just read them into the
Sure.
mic and then answer.
First question is working in performance. I'm fascinated by this work. Thanks for sharing. Wondering if concerns about optimal mindset around surgical performance also come up in this work. Things like visualization, breathing techniques, self-talk strategies. Yes, the answer to that is absolutely. That's in part why we're really excited about working on this virtual reality component, because with only 2 coaches to 45 residents who are in operative settings, it's hard to support everyone. But part of the work has been around introducing them in large groups to mindfulness strategies and visualization techniques that can support them. And we target this based on learner need, but the hope is to be able to do this with a larger group of people moving forward. The second is, can you speak to some to how the program works in outpatient settings? The program in outpatient settings follows the original modality that Dr. McDaniel outlined at the beginning. And so we're spending a period of about 4 hours in observation with the learner, whether that's a resident or faculty member. And our hope is to be able to really look for patterns and trends in their communication, that how they interact or interface with one patient may be different than how they interact with the next 3, and to really be mindful of and exploring that. Another says, and potentially the role can play in increasing efficiency while also increasing patient satisfaction. Yes, absolutely. I'm looking around, Dr. Garraway stepped away, but Dr. Garraway has done a lot of work with some folks on this very particular topic, as do all of us when we're doing this work, thinking about how we can do particular things at the initiation of the visit, like setting an agenda to be sure that we know where the patient wants to go, and so the patient knows how we intend to spend the time. So we definitely think about efficiency. We think about it in other ways as well. How are people using the computer in the room? Are there things that they could be doing differently? Your presentation made me think about how few of our faculty have formal training in family therapy and systems thinking. I'm wondering if there are opportunities for educations in this realm. 100% yes, there are lots of opportunities in this regard. The easiest is probably the marriage and family therapy intensive, which happens in the summertime. It's a 1-week program for people to have introduction to this type of content. And there are also, there's a post-degree certificate that is focused on these themes that folks who have a pre-existing degree can engage in. And I'm glad to answer more specific questions about that, because that's a different hat that I wear. And what about referrals for psychotherapy for burnt out residents? I think that's the last question. With regard to the intersection of burnout and these topics that emerge, I think part of what is helpful is that because we are all trained in behavior change, that we can walk up to conversations around what are the influencing factors. And for many folks, they'll identify the system stuff, but for many, they'll also identify other things that are happening in their life. And so we will work very closely. In every resident interaction that I have, whether that's one-to-one or as a group, I identify that I am not the clinical psychologist, I'm the coach, but that we want to connect them to resources. And so we work very closely with EAP, BHP, and have a list of resources external to the hospital as well for those who prefer to take that path. So it's something that we do regularly, but are also mindful of playing a supportive role rather than a direct role in addressing burnout or other symptoms. Yes.
I'm going to continue to hold on to one line that you very briefly said, and I want to come back to it. This idea that a system of practicing modeling behavior and silence as assent for continuation of whatever a trainee is doing is really an experience that I had in training, and certainly I agree that that's insufficient in the learning environment. Curious about faculty resources for faculty development to do more than how they trained, and also to think a little bit about like what specifically do our current trainees need and how can we embed that in our day-to-day practice, again recognizing what limited time we have.
Sure. So the question was regarding silence as assent, that resident behavior is going well and that's the feedback, and how do we move faculty toward a direction of having additional skills that build off of their existing capacity as physician educators. So I think 2 things come to mind in response to that. There are, part of what we all do as senior coaches is go out and we will work with departments and give sessions on how do you give feedback. And really, I don't want that to be didactic in nature. I want that to be something that engages people in a way that they're practicing the skills. Giving feedback's hard. It's not a comfortable process, especially when we see that people are struggling, but there are strategies that we can use to that end. And so helping people develop them and think about how they build those into their own repertoire. The second thing that we'll do with faculty in the departments where we have embedded coaches, especially, but all over the place, is to really work with those faculty one-to-one in coaching relationships so that they get to have firsthand feedback. They'll know what the program looks like. They'll be the recipient of feedback so that they can hear it in real time and think about how that then applies to how they give feedback. And then we think about what are the ways in which we can promote them as educators. It's not just about their bedside interaction or outpatient interactions, but it's really who they are as a communicator in other ways as well. And so offering feedback in what we see in team context or learning context too. So both of those things are available. I'm not here to do a marketing campaign because we're pretty booked, but we are also glad to help when it is needed.
All right, well, thank you, Susan and Lauren. That was really great.
Thank you.